This is Augusta DeLomo on November 20th, 2024 at 10:11 a.m., conducting an interview for the Global Oral History of PEPFAR project. To begin, could you start off by introducing yourself and establishing your connection to PEPFAR and what years you worked in partnership with them?
Thank you. I'm Dr. Kenneth Castro, and I'm a professor at Emory University presently, but spent a lifetime at CDC, and I started as an EIS officer in what was called the AIDS activity back in 1983. So we were at the early stages of the AIDS epidemic, engaged with the discovery of what was this about, what were the routes of transmission, what were not routes of transmission, and over time became increasingly engaged in the global aspects of HIV. During that time, the early stages of what later became known as PEPFAR were developed under the leadership of Dr. Helene Gale, and I think it was called the Leadership Investment in Fighting an Epidemic, or the LIFE Initiative. And the early tranches of resources were made available, only to be subsequently followed by the President Bush administration, which fully endorsed it, funded it. I think it later became the Lantos Hyde initiative, and then PEPFAR as we now know it.
Could you tell us briefly about yourself and your family? Where and when were you born? Where did you go to school? How did you come to be in the field of medicine?
So I was born in Puerto Rico and grew up, went to college there, and from there went to medical school in New York. Did my internal residency training in Montefiore Hospital between 1980 and 1983. I underscore the years because that's when we saw the onslaught of the early cases of people who were being hospitalized with bilateral pneumocystis pneumonia, toxoplasma encephalitis, and all these other severe opportunistic diseases with a very high mortality rate. Something that was flustering for young clinicians who wanted to really do the work of saving lives, and despite all your best efforts, these were almost universally fatal conditions. And at the time, I was reading about the early reports of AIDS and the Morbidity and Mortality Weekly Report, and keeping up to date with that. Once I decided that I wanted added training in epidemiology, I came to CDC, and in the Epidemic Intelligence Service, or what we call the EIS program, I matched with the AIDS activity and started working with them in a series of early projects.
How would you, at the time, could you set out for us a little bit about what was known about HIV at the time when you start, and what were the questions that you all were really trying to answer in these early days?
So first of all, the acquired immunodeficiency syndrome, if you go back in history, had different names. The GRID was one of the early descriptors. Over time, there was a consensus that emerged to call it the acquired immunodeficiency syndrome. If you go back to the early writings, we described the syndrome and consistently stated it's a new syndrome of unknown etiology. So we didn't even know what was the cause. However, because of its epidemiology, it behaved very much like a transmissible agent, likely similar to hepatitis virus or other similar viruses. And at the time, we were really concerned, number one, about the natural history. Number two, what were the routes of transmission, as well as what are ways in which this is not transmitted, because there was a lot of fear surrounding AIDS. During the early days when you had many gay men dying of the disease, you had people basically being ousted of their jobs, of apartments, and once they died, the apartment wouldn't necessarily be resold easily because of all the fears and stigma associated with HIV. In my particular case, I started working on the small fraction of people reported with AIDS who had none of the identified risk factors. Early on, we saw that people who were gay or bisexual, later we focused on practices, men who had sex with men rather than on labels, people with hemophilia, people who were injection drug users, and early on, people of Haitian ancestry who had been in the United States were being reported in New York and in Florida with this disease. Then over time, we learned of its occurrence in African countries and a tendency to not even acknowledge the existence of this disease in other parts of the world.
So you've mentioned this role as an epidemic intelligence advisor.
Mm-hmm.
What does that mean? As someone who is not a public health person, if they're listening to this, tell us what that kind of role entails.
So the other name that we commonly go by is the disease detectives. So these are the people who are sent to collaborate with local health department jurisdictions when there's an outbreak, investigate the causes, and then use the data to formulate evidence-based interventions. And you cover both infectious and non-infectious diseases, environmental conditions, etc. So during that time, you're getting trained in the applied principles and practice of epidemiology as a key backbone of public health. And at CDC, we were under a lot of pressure to come up with guidance and recommendations, and that guidance needed to be as best evidence informed as possible, and that required then getting out into the field, doing studies. Early on when I arrived, there was a big case control study of AIDS in gay men to look at what were the precise risk factors that were conducive to transmission. I was involved in studying it in the Haitian Americans, and trying to identify risk factors for it, as well as in managing the clinical condition at the time, which consisted mostly of preventing the occurrence of opportunistic diseases because we didn't have any antiretroviral agents. The other group that I alluded to were people reported with HIV who didn't have any risk factors, or we call it the NIR, the no identified risks. And once we did interviews, most of the time you were able to reclassify 2/3 of these persons into known risk categories, but which hadn't been disclosed for whatever reason. Either secrecy, didn't want the family to know, but it was always important to keep pursuing what routes of transmission are there that we're not aware of and need to know so that we can provide some evidence-informed guidelines.
You talked about the experience of young clinicians seeing HIV and seeing the way that this disease that was not really understood was wreaking havoc on communities. And can you tell us about how you got into this role, as you said, a disease detective? What was your drive to try to understand this from this epidemiological perspective?
The drive at the time was understanding that this was a condition we didn't know anything about. So here I am, graduated from medical school in 1980. AIDS was not in a single textbook of medicine. So it was something we were learning about in our residency training as we were exposed to persons and learning about it. So that there was that aspect of curiosity that comes with here's a new condition, how do we learn about it and what needs to be done. Also trying to be mindful that these were very stigmatizing conditions and being trying to avoid adding fuel to the fire. The very famous a child with hemophilia, Ryan White, after whom the Ryan White program is named, was ostracized from school. He was kept away by others who were fearful that they were going to get AIDS just by having this child in the same classroom. So that these were the things that we were confronted with. And there was that level of medical curiosity. So this is something new. How do I learn so that we can identify and better treat persons with this disease, and and do the interviews that were required. I myself had to learn how to conduct very in-depth, explicit sexual practice interviews without blushing. And over time, we would ask people about when did you have first sexual encounter, how many partners, what were the practices, and the same thing with people who used substances by needles. What kind of drugs were you using? Were you using by yourself? Were you sharing your equipment, paraphernalia? So all these were the questions that were being asked at the time of people. I should add the other area that I ended up having to investigate was the occurrence of AIDS in a cluster of people in Belle Glade, Florida. And there, a couple of clinicians raised the hypothesis that maybe this was a vector-borne disease. It was the insects in the community. And we had to get out and investigate with an objective, open mind. If indeed the case, then we need to come up with recommendations. But what we found was the opposite. We did arboviral serology. We worked with people who specialize in vector-borne diseases and found a community where you saw a lot of injection drug use, a lot of sex for drugs, and sexual activity conducive to HIV transmission.
You were in this role for about 6 years within the Epidemic Intelligence Division of the CDC. What, when you look back on that time, do you see as your biggest successes?
Looking back at that time, so I did the Epidemic Intelligence Service for 2 years and then remained as a medical epidemiologist. And I think at the time was learning how to work with other professionals to develop consensus and identify the areas that you had to write about to describe as accurately as you could the epidemiology of what was taking place. One of the things we learned during the study of AIDS in Haitian Americans was that it was not just being from Haiti that it conferred a risk. It was having sex partners who were infected. We saw a lot of heterosexual transmission at the time, and we didn't uncover other risks separate from what was known, and that prompted us to drop that risk category as it had existed. Early on, you may have heard of the 4-H club, hemophiliacs, heroin addicts, the Haitians, and homosexuals. And we had to move away from that very stigmatizing language and make better use of the science. I also learned immensely from colleagues who were sociologists and not in the field of medicine. Bill Darrow comes to mind as someone who had done a lot of work in sexually transmitted diseases, taught me how do you really do an investigation that respects the confidentiality but still pursues the truth. And those were some of the areas that come to mind. Certainly being able to dispel the myth that HIV was transmitted through insects was another proud moment. Then as time moved on, I was involved in updating the case definition and the classification system for HIV And again, working with others, that was not a single person work, but working with others to arrive at consensus, working with the World Health Organization, that matters.
It's striking to me when you talked about being in medical school and not being able to read about HIV, but you're seeing it in the clinics where
Right.
you're working. And can you tell us why having things like case definitions is so important when you're thinking about not just treatment, but policy that's designed to combat these kinds of epidemics?
Well, in the field of epidemiology, whenever you do surveillance for any condition, you need a clear case definition, so that when people are reported, we're all consistently talking about the same thing and not mixing apples and oranges. And so that's a key component. And then the other component is you collect the data, but you want to feed it back. Data that's collected and not analyzed and not used defeats the purpose of it. And that was very much needed, so that as we learn more about the different manifestations of AIDS, we needed to keep updating the case definition to really follow the science and reflect the reality out there. So early on, people with AIDS had to have a number of conditions that were reasonably diagnosed. Not, I think this has AIDS. Here's evidence of pneumocystis pneumonia, both by X-ray as well as by lab findings. Here's evidence of hepatitis, evidence of toxoplasma, of esophageal candidiasis, and other such conditions. And over time, we expanded it to include other gastrointestinal parasites. Generalized lymphadenopathy was another condition seen. And then once the virus was identified and we had serologic testing for it, we also included evidence of HIV infection as part of the case definition. So it was a whole evolutionary process that we witnessed and we're part of.
And you're working here primarily in the domestic U.S. context, but as you pointed out, the global AIDS crisis is still part of the calculation that you all are making at this time. Can you tell us about how your sense of the global epidemic, maybe how it felt similar or different to what you were seeing domestically, or just the ways that influenced the kind of work that you were doing?
Well, early on, it was very much a domestically focused activity. And in other parts of the world, you weren't hearing much. In fact, the world was looking at the United States as the epicenter of the AIDS epidemic. And over time, I started working with the Pan American Health Organization to help provide guidelines for countries as they started seeing their first new cases reported with AIDS. I found it very interesting that in almost all countries, the early cases had a history of being in contact with the United States. Gay men who had fled the country and had lived in either New York or San Francisco came back and probably contributed to transmission in their country of origin. And in many instances, again, when these conditions were so stigmatized, there was secrecy surrounding this. You would talk with their clinicians, but they wouldn't say much about it. And in all of these countries, they needed to develop a surveillance system, policies, and I was helping with that. Being originally from Puerto Rico and being bilingual and bicultural enabled me to work in Spanish and work and write things in Spanish with the Pan American Health Organization in many of these countries. And it was interesting to observe how many of these countries were lagging behind what we were witnessing in the United States. Our numbers were skyrocketing and they were just trickling in these countries, but there was a rude awakening taking place. The other thing that I saw at the time was Dr. Jonathan Mann, who had been the state epidemiologist in New Mexico, was hired by Dr. Jim Curran to go to Kinshasa, Zaire at the time, now the Democratic Republic of Congo, because there were case reports happening there. And one of the things that he observed was that no Minister of Health wanted to admit that there was any such thing as AIDS in their midst. And part of what was required was an admission that, yes, indeed, there are these people who are severely ill, dying of a very strange condition, and that research needed to be done, documented, and policies evolve. And in many of these settings, there were no facilities. These severely ill patients that required often intensive care unit, ventilatory support, and in many of these settings that was not present. We did see also many other opportunistic diseases different in other countries. Tuberculosis was a leading cause of death among people with AIDS in many of these settings, unlike what we saw in the United States, at least early on.
What were the years that you worked with the Pan American Health Organization?
I worked with them from 1985, I believe, through the 2000s. What they did was they developed an agreement with CDC to have me be available to them as a technical advisor and call upon me when needed. And we would visit countries, do assessments, work with both physicians, give presentations to describe what we were experiencing and seeing in the United States, and then have the opportunity to open up and listen to their experiences in many of these countries, and then work with the Ministry of Health to develop policies and plans. The early AIDS action plans came about during those days.
Can you sketch out for us a little bit, and you mentioned this already, the way that the epidemic really did look different in the U.S. and in other places. In 1985, when you start, it seems to be coming from Americans who are going to these places. But you worked there with them for over a decade. Can you talk us through how the epidemic looked in some of these countries in ways that may be different or similar to the U.S., and really how that changed over time as the global AIDS crisis really comes into our sort of contemporary understanding by the 90s and 2000s?
So what we observed in many of these countries was, number one, a slightly different occurrence of the opportunistic diseases associated with AIDS. Secondly, the risk factors, you saw a larger proportion of people who seem to have been heterosexually acquired HIV infection, both men and women, not only men. You also saw in many of these settings, bisexuality was quite common. In countries where the man had to retain the facade of being a heterosexual, married, etc., but had this secret life, we saw that often in many of these settings. It also varied by country. In Argentina, we saw a lot of injection drug use associated HIV. We saw that in places like Puerto Rico. And even in the United States, you saw it much more commonly in New York City than you saw it in the West Coast, in San Francisco. So each country had a developing epidemiologic profile of risk factors for HIV. At the end of the day, they were all the same. It was infection acquired through exposure to blood, body fluids, whether through sex, transfusions of blood, or in the case of hemophilia, people who needed factor VIII to control their hemophilia. A very interesting scenario that I ended up contributing to investigate in Mexico was a cluster of HIV-infected blood donors. And we ended up uncovering that many of these paid donors who would go and donate blood for plasma, and they were plasmapheresed, it appears that some of the IV equipment was reused and contributed to transmission in that setting. And there again, by the time we made it to Mexico to help investigate that, the authorities had shut down many of these blood collection entities, and it was difficult to then investigate. But we were able to work with the Ministry of Health people, do a survey in Mexico City, and identify some of the residual or surviving donors, and identify those risk factors. So, as you can see, it's the pursuit of what's causing this and what's the truth, so then we can use that to guide what needs to be done.
What were the systems like in place that you mentioned this, the Ministry of Health and the way the local authorities were, shutting this down and not necessarily wanting further investigation? What systems did you see in place of what existing sort of surveillance structures existed to try and track HIV before you all came in? And what were some of the things that you all tried to advise or put into place to kind of get a more systematic handle on what was actually happening on the ground?
Well, early on, there was a lot of denial by many of these authorities in the Ministry of Health, and you really had to work with practitioners. So the organized professional organizations, for example, I interacted and was a member of the Pan American Infectious Disease Specialists, or API is the API is the Spanish acronym for them, and they exerted pressure within their governments so that people would awaken to acknowledge the existence of AIDS. But it didn't always happen spontaneously. You did have some enlightened leadership in many of these countries where they wanted to tackle the problem and deal with it, but other countries just wanted to sweep it under the rug and say, no, well, that's not a problem here. That's over there where you have all these gay men, which we don't have here in our midst. So it was interesting because you had to navigate these difficult scenarios. Because we worked with the Pan American Health Organization, that provided an entry point in many of these places. If I had arrived as a private citizen, why should they have listened to Ken Castro? But going with partners from PAHO, who have established linkages in the ministries of health, facilitated those transactions.
And all of this work is obviously pre-PEPFAR, and I'm curious if, as you start really doing this global work and seeing what the global crisis looks like, if it started to influence your thinking about should the United States be doing more, like how did your thinking about what American global intervention around this disease changed or evolved in this period?
Yes, absolutely. Once it became evident that AIDS was not confined to the United States of America and it was a global phenomenon, then we saw the need to make sure that other countries were keeping track of it, were addressing it, and were providing measures for prevention. At the time, we had nothing to offer for treatment beyond the treatment of the various opportunistic diseases. In fact, some diseases were very difficult to treat, such as Kaposi sarcoma. But most of the other infectious conditions you could treat only to have them recur because people were so immunologically depleted that they had recurrent disease until they succumbed to these. But we did see that there was a need to address it globally. One of the first things I learned in the practice of public health was that if diseases know no borders, why should our interventions stop at our borders? And we needed to be global citizens and address that. Then it became a matter of resources. Who's going to pay for it? Are the countries going to step up? Is there any role that the United States should play? And that was all early on undefined and uncertain.
You mentioned at the very beginning of our conversation the life initiative that Dr. Helene Gale put into place and worked on and that you saw. Can you tell us a little bit about that and when that program came into play?
So that program, I think, first came into play around 1999, and it was a discussion. Dr. Gale had been involved with others in the implementation of field sites to assess what was going on with AIDS in different African countries. So the first one was in Kinshasa, but soon thereafter there was a site in Abidjan, Cote d'Ivoire, where early on the studies being done by Dr. Kevin DeCock were to establish whether HIV-2 was just as bad as HIV-1. And over time it became apparent that HIV-2 was less serious, and what really mattered was HIV-1. People who were co-infected with both variants of the virus were certainly at higher risk of bad outcomes. But that led to understanding more about HIV. Then we also had people in Thailand, and in Thailand there were two separate and rapidly growing epidemics, one affecting the injection drug using community and the other one the sex industry. Many of the women who were part of the sex trade in Thailand, which was Bangkok was famous for in Asia, and where people went to have sex with young women. And these were two separate epidemics with two separate viral clades that became apparent. So that all that was being studied, but it deserved more than study. What are you going to do about it, and what are you doing for the people who you're interacting with and studying? At the time, antiretroviral treatment was also becoming increasingly available. And I distinctly remember the International AIDS Conference in Durban, I think it was in the year 2000, where the theme was One Hope, and the activists were saying, whose hope, and who's getting access to it. And so then the movement started emerging about the disparities that were existing throughout the world. Yes, there was a lot of discovery. Early antiretroviral treatment was being made available, but it was only in the high-income countries, and low and middle-income countries were being left out of that. And the LIFE initiative tried to address that gap.
Can you explain to us, for again, for someone who's not a public health person, why is antiretroviral such a game changer? And what did the cost disparity really mean in practice when you've got something like the LIFE initiative that is trying to address that gap?
Well, antiretroviral therapy, especially the so-called highly active antiretroviral therapy, or HAART, H-A-A-R-T, early using protease inhibitors, were extending the lives of people beyond the usual 2 years. And in fact, now we've evolved into a situation where someone with AIDS is expected to have a normal life expectancy. And what I've told people in clinic when I see them is, this is no different than hypertension or diabetes. You're going to be on drugs for the rest of your life, but you are probably not going to die of this. You're going to die of something else. In those early stages, those drugs were too expensive, even in the US, not always covered by health insurance schemes. That's what required the Ryan White program and HRSA to contribute with programs that would provide insurance coverage for the antiretrovirals. And in other countries, they were just plainly unaffordable. And programs like the LIFE initiative, later PEPFAR, rolled out ready access to the antiretrovirals and became a real game changer, because in places where you saw people, I hate to say this, but the reality was dropping like flies, were all of a sudden surviving and leading a healthy life expectancy.
Do you remember where you were when PEPFAR was announced, what you were working on?
I don't really remember. I was probably, I had already started working on tuberculosis, because in the United States we had a big outbreak of multi-drug resistant tuberculosis affecting mostly persons with HIV. And I had been working from that role with Dr. Gale and others. And when the Lantus Height Initiative was announced and funded, because you can have something authorized, but without an appropriation and funds to accompany it, it's just words in paper. So that happened over time. I don't think that there was a single date. At CEC, we had the Global AIDS program, and early on, Dr. Gale, Dr. Eugene McCrae, Mike St. Louis played a role. Later, they hired Debbie Burks to run that program, and then she became the PEPFAR coordinator over time. But it all followed a series of baby steps that had been taking place up until then, where you could stand up, walk, and run.
When you talk about the baby steps, the Global AIDS Initiative at CDC, the Life Initiative, what were the points that you think, okay, this really laid the groundwork? What would be those building blocks that you would say allowed a program like PEPFAR to be stood up and funded, to your point?
Well, a lot of the work that was being done, so CDC and NIH collaborated in the Progesida is the original name of the project in Kinshasa, Projet Retro C in Abidjan. So Retro CI stood for Côte d'Ivoire. Then there was a project in Thailand. Then there was a lot of work also going on in Australia and other European countries that were providing proof of principle that if you intervene, you could really make a difference. So that to me were the field stations that provided the opportunity to do more and demonstrate that if you did more, you could make a difference.
We've heard a lot about when the Bush administration put together PEPFAR and that they were not as interested in working through something like the Global Fund and wanted more unilateral control, and that in some ways factions of CDC, USAID felt left out of kind of the initial collaboration process of developing PEPFAR. And I'm curious, as someone who was in those spaces, if it did feel like the CDC and others were kind of left out of those initial conversations, but they become the primary implementing partner. So I'm curious how you see that.
Well, I don't know how the decision was made to place the Office of Global AIDS, or OGAC, the AIDS coordinator, outside CC or USAID. In fact, it was in the Department of State. And probably it was just the politics of the powers that be who decided that this needed to be above any of the agencies. But you could have theoretically placed it within CDC, within USAID, or developed an interagency entity with NIH and others. But I'm ignorant about how exactly that came about. But what we've all learned to do is you take it as it comes and you make use of what's available to you, rather than, okay, this is not necessarily the way I would have designed it, but given its availability, how we make inroads and progress. But I can't say that I felt that CC and USAID had been excluded. Certainly didn't have the leadership role that you would have expected to have seen, but they were certainly consulted, and the technical input was very much reliant on the scientific leadership that existed in all these agencies.
When you think about these baby steps that now then come into PEPFAR, can you tell us what that game, people have described it as a game changer, like that game-changing effect of PEPFAR? What are the things that you saw that seem to come into place? Obviously it's money, but what is the capacity building that is now able to be done with something like a PEPFAR?
Well, PEPFAR has enabled not only the availability of resources and mobilization of resources, but also a trained workforce to be available, and ideally in the process building local capacity so that countries are not forever dependent on external donor funds and resources to get the work done. And there are some places where there is immense leadership. South Africa produced some of the best science. And in many of these other countries, you have people from other settings who were leading these programs and who we were working with, whether it was in Zambia or Malawi or in Botswana. And PEPFAR has been an enabler. And again, if you had a local minister of health who might have been reluctant to make investments in addressing the HIV epidemic, having a bilateral program with PEPFAR where they say, we're bringing resources, we're bringing a commitment, a longer term commitment, and PEPFAR has always operated, interestingly, the country operational plans, or so-called COPs, which are supposed to come from the countries, but the countries in turn receive guidance from PEPFAR, and some people think it's too top-heavy. Others say, well, let the countries determine what's needed. I think what you need is truly a combination of both, where PEPFAR says, here's the best science, here are the best regimens available, and the countries say, here's what our needs are, and how you match these two is the best way forward, in my humble opinion.
When you think through, the kind of what you're describing, these plans, we've heard a lot about PEPFAR's reporting structure, that there was a lot of concern from the Bush administration about they wanted to make sure the money was being spent and that it was being spent in ways that, the U.S. government bureaucracy, you report every penny that you spend. Was there a sense when you've been seeing these projects, working on them, of how PEPFAR's reporting was similar or different than other sort of global health programs that you had been a part of?
I think that PEPFAR had many more requirements for accounting of the way the resources were spent, trying to put some guardrails against potential fraud that would come about in impoverished settings, where all of a sudden you throw millions at the country, and where there's always a risk that the money could be siphoned off to do something else. So PEPFAR was very strong in that accountability framework that they provided. I think it was Randall Tobias who started as the first OGAC administrator, and then he quickly moved on, and others have kept that sense of accountability. Randall Tobias came to the government from industry, so he adopted that business model, and I think that it has permeated through, although it has mutated and evolved over time. But you see that obsession with accounting for numbers, and sometimes even at the risk of being a bit too forceful. So the data need to conform to a certain metric. The tableau that's used by PEPFAR for monitoring, evaluation, and input is often perceived as too heavy-handed. But I think that over time it has, especially under John Nkengasong, you've seen that there's a better appreciation for what the country has to offer, so that it's more of a bilateral agreement that you see happening nowadays over years.
You mentioned your career. You shift and work primarily on tuberculosis, and you mentioned briefly HIV associations with TB. And again, for people who are not public health oriented, why are HIV and tuberculosis linked in this way? You go on any CDC websites, the National Center for HIV, Hepatitis, TB, that they're linked together. Can you tell us what that interaction is and why personally you shifted to focus more on TB.
Well, I shifted as a result of getting involved in outbreak investigations. What we saw between 1985 and 1992 was a resurgence of tuberculosis that was totally unprecedented. We had more than 30 years of declining tuberculosis trends in the United States, only to have them come to a screeching halt and go up by 20% during those years that I just mentioned. And what we saw was that multi-drug resistant TB outbreaks were occurring in hospital settings, and not only patients, but many of their practitioners were also developing multi-drug resistant TB and dying of it. Not surprisingly, you often see in these very large cities gay physicians treating their gay clientele, and many of these clinicians ended up dying. I remember there were two gay dentists in New York who had as their clientele many of the people with HIV, who preferentially went to them because they were very open to the treatment of these patients at a time when maybe other dentists might have not been so welcoming. But I did see a couple of them die of multi-drug resistant TB at the time. Then the other thing we've seen is that if you go to countries such as Haiti and sub-Saharan African countries, tuberculosis is one of the leading opportunistic diseases associated with HIV. And in fact, to this day, tuberculosis is the leading cause of death in people with HIV, accounting for a big fraction and requiring PEPFAR to pay special attention to identifying tuberculosis among people with HIV, because it's really sad to be given antiretrovirals only to succumb to tuberculosis because you were not identified or treated for it. Given that association, I felt very, it was almost like a destiny. So here I am, I'm working on HIV, start working on TB that's HIV associated. So these two pathogens have been the focus of my career. And nowadays, I've also seen that way beyond HIV, tuberculosis affects people who don't have HIV infection, especially if you move to Asian countries. India accounts for 1 out of every 4 TB cases, and HIV is not the leading cause of tuberculosis there. It's going to be diabetes, undernutrition, and other problems. And so we've seen the need to also address the non-HIV component of it. And PEPFAR has been remarkable at beefing up the programs in especially sub-Saharan African countries. You know, when I was working in Botswana, we started the Botusa project there to look at both TB and HIV. If you went to a TB clinic and you did a sero survey, at least 60 to 70% of TB patients had HIV infection. So when I saw that, I said, TB clinics in African countries are HIV clinics in disguise. So we really can't address TB without addressing HIV. And PEPFAR has really strengthened these links and ability to address both conditions. Now, the other work that PEPFAR hasn't been able to accomplish is what's being accomplished through USAID and CDC, and it's tackling tuberculosis in its own right.
When you see the HIV-associated TB, especially in this clinic in Botswana that you were working with, can you tell us a little bit about, you know, what it meant in practice to actually treat both of these diseases simultaneously? Like, take us there. Like, what is the kind of work that you all did day to day?
So to address both conditions simultaneously, early on we had remarkable challenges. Number one, if you were treating people with a recommended treatment for tuberculosis, one of the drugs is rifampicin. Rifampicin is notorious to cause drug-drug interactions with almost any other drug that's metabolized by the liver. And when antiretrovirals became available, many of the protease inhibitors were interacting adversely with the rifampicin used for tuberculosis. So we needed to come up with new guidelines on the proper management. And early on, people would say, well, treat TB first. Once you're done, then start antiretrovirals. And many of the research studies try to address what's the optimal time. Should you treat them both at once? And then the other thing we were seeing that was quite remarkable is what was called the paradoxical reaction or immune reconstitution reaction. You start someone on antiretrovirals only to have a worsening of their tuberculosis. All of a sudden, a brain lesion that was not previously evident became manifest, and that required a recognition of the entity so that you could manage it. So yes, you continue the treatment for TB, but in that setting, you might need the use of steroids that you might have not required previously. So those were some of the management challenges, but the challenge starts with recognizing that both entities were present, and very often you would test for one and not the other. And so much of the research and applied or implementation science that has taken place has helped elucidate what are the optimal practices in these settings. Then the other thing we've learned is that if you have HIV infection and you live in a country with a high TB burden, you probably benefit from TB preventive therapy. And early on, that was thought to be a lower priority. That was not necessary. But lo and behold, in people with HIV and immune deficiency, you better pay attention to TB infection before it becomes a problem. Then the presence of drug-resistant TB posed another challenge because that treatment, up until a couple of years ago, required 12 to 24 months of treatment with injectable agents. It was an absolute mess and nightmare for clinicians and patients. The side effects of treatment for drug-resistant tuberculosis were deafness and renal failure very commonly because the drugs that were required induce those side effects. Now we have been able to move away from these injectable agents, have fully oral regimens for people with multi-drug resistant TB and can be used in 6 months. But that's only within the last couple of years. So, yeah.
It's really striking to me, talking about how PEPFAR has evolved and it's how the program has changed over the past decade, especially when you think about how the Bush administration talked about it initially, is they were really focused on drugs in bodies, that they really wanted to see that it was a medication-based program, and talking about how you get a program like PEPFAR to see that TB is important in this HIV equation. Can you tell us more about that and when you started to see the shift and when you were able to see what that kind of looks like in practice?
It's interesting that you would ask that question because I remember some early not very friendly conversations with the powers that be. Mark Dybul, for example, was very sensitive to the needs of tuberculosis, but he didn't want to see the resources for PEPFAR siphoned off to deal with TB. And early on, we would argue that in many of the sub-Saharan African countries, separating the two diseases was artificial because the reality was that they were both commingling. In fact, Dr. Jim Curran came up with a great statement. He said, TB and HIV hang out together and they're a bad influence on each other. I told him this is a very grandmotherly type of statement. But that was the reality in these countries. And early on, there was some hesitation because of the perception that the resources, if they went to address the unmet needs in TB, would dilute the antiretroviral rollout. Over time, to their credit, they saw the reality and then they made it a priority as part of the integrated program for addressing HIV in these countries, where TB is one of the leading infectious conditions that you see in people with immune deficiency. But it took time. It wasn't spontaneous. I remember being on conversations where we would hear statements such as, well, if the person in the clinic has HIV, then we'll cover them. But if they don't have HIV and they have TB, we won't. And so that was, how do you do that in a clinic and to a human being? But those were some of the struggles we went through. And, I remember early on with Mark Tybel, later Eric Gooseby, and then Debbie Burks. But one of the beauties of the data and the truth is that they ultimately become self-evident. So even people who might have not believed that was the right thing to do became convinced based on the data that, yes, this is something we must address.
It's really interesting hearing you talk about how the programs are evolving, but the CDC is evolving to match the purview of the powers that be to make sure these resources are being used. Can you tell us a little bit about, as someone who has been with the CDC for so long, the ways that you see PEPFAR, how it changed the CDC, the ways that the program shifted the kind of work they do or amplified it, what that kind of felt like as someone who was working in those rooms?
Well, now you have a whole workforce that exists almost as a foreign service, moving from one country to another to help implement PEPFAR. And in doing so, they developed the skills of working internationally with sovereign countries, sovereign ministries of health, and trying to negotiate the ability to arrive at consensus, what's the right thing to do. How do you also do it in a way that's not stigmatizing? We haven't touched on the dark ages in South Africa, where under, I want to say Mbeki, but I could be wrong, he denied the existence of HIV as the etiologic agent of acquired immune deficiency syndrome, and pretty much blocked access to antiretrovirals. And there was a big uproar in the community in South Africa, and over time, they certainly have become leaders in the rollout of ARVs. But early on, there was those dark years of denial. So you can see how someone from the United States working those settings has needed to evolve to address these needs. The other thing that has happened globally is a term that's loosely used and abused, decolonizing global health. How do you come into a country and not act as the old colonial power? I know better for you and what you need to do. And PEPFAR has had to evolve into that. Early on, it was seen as very top-heavy, very U.S.-driven policies. Even the purchase of antiretrovirals required FDA-approved antiretrovirals. Over time, that evolved. I remember Brazil saying, PEPFAR, keep your money because we want to be able to buy antiretrovirals elsewhere. We can produce them ourselves. They can be purchased from elsewhere. And early on, there was the sentiment that, you needed to provide quality assured drugs. How do we know that others are as quality assured as our own FDA? Others would argue that you're protecting U.S. interests and U.S. big pharma. So there's all that controversy surrounding also the way that PEPFAR has been implemented. But again, the beauty of it is that over time it has evolved. And yes, other antiretrovirals produced elsewhere that are quality assured can be used in all these settings.
When you talk about the dark days of denial, as you called them, in South Africa, but also globally, can you tell us what that was like and the kind of relationships that you're trying to build and the work that you're trying to do amidst this climate of conspiratorial denial from a government that you're trying to manage? Tell us what that was like.
Well, it's difficult, but you quickly learn that there's always a way. I mean, even in right here in Atlanta, I got invited to talk to church groups at a stage when people believed that those with AIDS deserved what they got. I would say, okay, doesn't the Bible say that he without sin cast the first stone? So, and then the other thing that's been really good about this is that there's a role for the caregivers, and you see many of the Christian affiliated churches providing care to people with this deadly disease, and trying to stay away from whether they should use condoms or not, and things that the prevention messages don't need to emanate from these entities. And then there's the governments that people elect, and what you end up doing is you work with the activists, with the established professional societies, the clinicians and the nurses in these settings are not going to basically accept what the government has to offer when they're confronted with this onslaught of sick people. So you end up learning how to navigate these treacherous waters, again recognizing that you're operating in a sovereign country. You're not there to tell them what to do. So those are lessons of implementing these global health programs, very much influenced by the United States. So then we now have also, not only did we have PEPFAR as a big program, but the U.S. is the biggest donor to the Global Fund to combat AIDS, TB, and malaria. In fact, early on, we called it the GFAT-M, the Global Fund against AIDS, TB, and malaria. And in that setting, again, the influence, almost undue influence in the board by the biggest donor, and how do you navigate with other countries that are also donating money and are wanting to have a say, but that heavy, almost overt influence exerted by the United States. So it's, I will acknowledge it as a challenge, and it's an area that we're evolving to do better.
And especially when you think about evolutions in PEPFAR, the Bush administration's ABC approach, which you just touched on, is a huge part of the fights within Congress, the fights about what PEPFAR is going to say about abstinence, about sexual health, about reproductive health, and that approach changes with the Obama administration. And I'm curious, as someone who was there early days, how heavy the ABC approach really seemed to be a point of influence, what that looks like on the ground, and if that trickle down was something that you all felt as administrative changes happened.
I'm glad you mentioned the ABCs. Yes, so those were some dark times because of the policy implications and the directives we were operating under. But there again, you know that this is a party line, but then you work with the locals and you let the locals do what's right. Promoting abstinence and condoms as the only preventive measure was totally inappropriate. If you wanted to make a difference and acknowledge the lifestyles and the freedom of choice that people are supposed to have. Fortunately, and by the way, you see that if you're around long enough as I've been, you see the ebb and flow of policies. Under the Republican administration, they resurrect the Mexico City policy. Thou shalt give no money to any entity that uses abortion as a method of contraception. It doesn't matter what else you're doing, which could be saving lives in children who have diarrheal disease, but if the entity is perceived as also spending money in termination of pregnancy in the form of abortion, U.S. government policy is don't give them any money at all. With a change of administration, then they recant that you're able to invest in these entities. So you see it coming back and forth. What I personally do, and I think many of my colleagues do, is you don't draw attention to these inane policies and try to do the right thing and stay clear of trouble by not drawing attention to it. I mean, at the end of the day, I believe that we're here to provide the best service to the human being at the other end.
When you think about the PEPFAR years, and you're still in this field now, what are the moments that you look back on as you feeling that real success, the real impact of this program and this work?
Well, I mean, look at the trends, at the number of people, at the life expectancy, at I mean, you can tout that maternal transmission has been eliminated in places like Puerto Rico. I'm aware of that, being from Puerto Rico, interacted with some of the people who've implemented those programs. Those are remarkable successes. You have a generation of children being born free of HIV, even when their mothers might have been infected before and during pregnancy. And also, people who would have been out of a job because they were so debilitated are now leading a healthy lifestyle, fully employed, earning their wages because of access to these antiretroviral agents. And from that perspective, I've also come to appreciate how good health is a contributor to the economy, because if you have a healthy workforce, then yes, you can have productive lifestyles in every setting of the country.
And obviously, we're currently here in the Rollins School of Public Health, and I'm curious, what pushed your move into academia, and how you see the relationship between academia, government, civil society in this puzzle of how you combat global crises like HIV.
Well, in my case, I arrived at the time when I was done with my U.S. Public Health Service in uniform, and I still had plenty of productive life years ahead of me. It was a natural place to come to, given the interest, the ability to teach, and as I say fondly to my students, I'm not going to be around forever, and I want to make sure that there's a new generation of very capable people that can carry the torch forward and pass the baton to. The academia is great because you have a lot more freedom. And when you work within the government, you're constrained by government policies, the clearance procedures, and even when I've been very prone to always speak my mind, I was always on the edge of the precipice of, looking for trouble, but not quite jumping off the cliff. And in academia, you have an easier time. I mean, there was a time when I came here and there was an imposition on CDC not to use certain keywords, and I wrote an editorial about it. I didn't get it cleared the way it would have been at CUC. I co-authored it with Jim Kerr, Carlos Del Rio, and Dabney Evans. We talked about the 7 deadly sins if you don't use these 7 words, And there's a lot of research, innovation, creativity that feeds very naturally and nicely into programs such as CDC, NIH, USAID, to mention these few, obviously FDA also. But given our proximity to CDC, you often see our students doing projects with CDC, and personally I see that the beauty of that is that you see an application to the principles that you're learning about. They're not just a theoretic basis, but you see their application, whether it's at CDC with the local health department or some of the local entities. We have the Task Force for Global Health, we have the Carter Center, we have CARE International, all located within the same city, and making it easy for our students to get that exposure and potentially jobs after they graduate also. We also work with the local health department, whether it's the Georgia State, Fulton, or DeKalb County's boards of health. And I like to tell people that even if you're interested in global health, make it local, see what happens locally, because that's what enables you to come in a credible fashion to the people who you work with internationally. And looking back, I think that helped me a lot. Being able to stand before colleagues and talk about my personal experience managing people with HIV, dealing with surveillance definitions, etc., gave me a credibility. I was not just doing it from a theoretic basis. Yeah, so I think that there's almost a natural gravitation to a place like an academic environment, but not totally disconnected and feeding back into these other agencies dealing with health.
What were the 7 words that were banned in the editorial?
Of course, I knew you were going to ask them, and I'm not going to remember them, and I will look them up for you.
When you teach your students about PEPFAR and HIV, I'm curious, as you said, you can say to them, I was there in the early days when we didn't know anything about it and where we are now. What do you tell your students about those years? What do you want them to take away about this program?
Well, one thing that I underscore is that if you have a solid epidemiologic foundation, you can learn a lot. And if you look at the writings and CDC guidelines that came about between 1981 and 1983 when the virus was discovered, they're still sound because they were based on solid epidemiologic principles. What are the patterns of transmission? What are the risk factors for this disease? Even when we don't know the agent, this is the way it's behaving. Making sure that you are rigorous about the application of those principles and how they relate to reality. Then also mention that you should never be shy about confronting something that no one knows anything about because it's new. COVID is the most recent example of that. We had never seen anything like the COVID pandemic, and we had to learn, and we're still learning about the long COVID sequela. So also acknowledging that there's always something new to learn and to make it applicable to new policies.
What does your work now as a professor, but also just in your other hats? What other hats are you wearing now with PEPFAR and the global HIV crisis? What does it look like for you now?
So I'm staying almost too busy. I have an agreement with USAID to serve as a senior TB scientific advisor in the Division of Tuberculosis, and they have bilateral agreements with 24 countries, so I help with those and often get invited to be part of joint monitoring missions to see what progress is being made, what recommendations should be made for added progress, or what are you doing that you should maybe scale back and instead of pay attention to this. In the School of Public Health, I lecture in some epidemiology of TB courses, emerging infectious diseases, and teach some of the principles of public health. What are the core functions of public health for doctoral students who arrive to pursue a PhD in public health, but who don't have a background in public health. So that's a requirement that they learn the principles of public health. And I was teaching that. I haven't taught it this year. And then the area where I'm really becoming most invested in is helping students with their thesis project, mentoring them through how do you develop a thesis concept, the application of it, the rigor that it requires, but yet making it understandable at the end. And I also like being what Malcolm Gladwell described in his Tipping Point, a connector, making sure that, okay, here's an introduction, so-and-so, this person is interested in your field. Maybe you can identify areas of mutual interest and benefit. So I do a lot of that also. and still engaged then with PEPFAR and the Global Fund, providing technical support whenever they call on me to do that.
When you talk about being a connector, one of the things that we've heard a lot about is the bond that brings people together who have specifically worked on PEPFAR, but also those who have worked in the global HIV space. And I'm curious if that bond feels real to you and what that means in practice.
No, that, very much so. In fact, just to give you a very tangible example, the person from CDC in Thailand who helped describe the early stages of AIDS there was Bruce Wenninger. And I've invited him to lecture to our students, and he was an editor for a peer-reviewed journal, so on scientific manuscript writing, and so it provides these added connections, and then he talks about some of his work in AIDS at the time. The other thing I failed to mention that I'm doing is also mentoring and directing the Humphrey Fellowship Program. It's a Fulbright exchange program. And here we have 11 mid-career professionals of all fields of public health who then come to us trying to develop leadership training skills and hone in their technical expertise. They're likely to go back to their country of origin, get promoted, lead teams. So we're trying to build that capacity because people, what we've learned is if you come through as a technocrat, you may not be good at leading teams of people. And how do you really achieve that and do it well? So that's the other thing that we're doing, and I'm certainly enjoying. But yes, there's a bond, and you get out and you talk about these past wars that gave you all these scars, but our delight in seeing the progress that's being made. If the progress had not been made, then it'd be a whole different story.
When you think about maybe we'll phrase it as the progress that's still to be made, what are the areas where you would say you would like to see a program like PEPFAR do more?
Well, there's certainly many other conditions that don't have the attention, the awareness, or the resources that PEPFAR has had. And in fact, it reminds me how in the early days of CDC's response to AIDS, which later attracted resources, a colleague of mine at CDC came up with ARC. He said it stands for AIDS Resentment Complex. People who are in other programs, such as neglected tropical diseases, that are very deserving of attention, don't have, and as the name implies, they've been neglected over time. Conditions such as TB, which has been with us for millennia, have the dubious distinction of being a leading infectious killer, surpassing AIDS and HIV nowadays. And the resources, if you look at the Global Fund, they always underfund conditions such as malaria and TB, and yet AIDS captures the attention appropriately. And I say this to draw the contrast, not to say that AIDS should get less, is that other programs should get more to do what we've been able to accomplish with AIDS. You can see that if you make a commitment that's sustained over time, resourced, and the right people trained to do it and implement it, you could get wonders done. And we need that for so many other conditions. Non-communicable diseases, diabetes is epidemic in many parts of the world. In the field I work in tuberculosis, malnutrition and diabetes are the drivers of tuberculosis in settings where HIV is not as prominent as you see in African countries.
When you think about the push to have more funding for these other diseases, there's also a important backdrop here, which is the challenges of PEPFAR reauthorization.
Pardon me. Excuse me.
The bipartisan consensus that existed in early PEPFAR does not seem to exist at the moment. And I'm curious, someone who's watched the evolution of this program, your concerns about the future of PEPFAR, considering how difficult it was the last time PEPFAR funding was up on the congressional table.
Well, for that matter, I'm concerned about all health programs, both domestic and global. the in the new administration, I don't see a clear vision or appetite for investing in health programs. And the problem with that is that we will do that at our own peril. The moment you disinvest in all these programs, you're going to have resurgence of conditions we thought we had done away with. We've already seen the occurrence of measles. In fact, there was a ceasefire in the Gaza area because there were clusters of measles in the middle of the ongoing attacks. And PEPFAR disrupted health infrastructures in manners that we now have the lowest rates of immunization in many settings. In TB, we also saw a reduction in the recognition of TB cases, yet an increase in deaths, only to now be recovering from that. So anytime you disrupt an infrastructure that's required for the long-term maintenance of a program, you run the risk of having it come back with a vengeance. So we are bracing ourselves for disinvestments that we're going to only recover from by throwing a lot more money than what we thought we had saved. That's the short-sighted nature of what appears to be the approach by the new administration. And as you yourself mentioned in your question, we've seen that Congress has become paralytic in its ability to work across party lines to develop consensus on these bipartisan legislative proposals. So that's worrisome. And I'm hoping that if we see that, we take some corrective action during midterm elections.
Yeah, I have a couple of questions.
Yes.
And when you answer them, just look at it.
Okay.
Pretend. But can you take us back to the early 80s? You're a newly minted doctor. What is it like for you to see the emergence of HIV? Like, how terrifying was that? Can you sort of walk us through what that was like personally? Because looking back on it now, of course we know now how it's transmitted. I'm struck by you talking about this cluster in Florida where you have to go down and investigate how this is happening. That's so scary.
Mm-hmm. Yes. I mean, as an internal medicine intern and resident, you spend your time in the hospital. So as people are being admitted, all of a sudden you see the wards becoming replaced instead of people with congestive heart failure and all these other chronic conditions. Then you have people in intensive care unit with bilateral pneumonia, people who have meningitis requiring attention, and things we hadn't seen. Or if we had seen, it was before my generation. We thought we had done away with these conditions, and that was scary. I remember doing a rotation through the hematology oncology unit and finding someone who was diagnosed with a very rare form of parasitic infection found in the bone marrow. And we were all looking at it on the microscope, looking at textbooks, and the head of the pathology department saying, I had never seen this in my life. I had only read about this. So those are scary moments where you're facing the unknown. And even people making the gallows humor type jokes, you're looking at the blood result slips and one of the residents saying, oh, this person has AIDS, throwing the slip aside, saying, I don't know, that's the way I'm going to be able to get infected with this or get it. It was in a humorous mode, but it was gallows humor nonetheless, reflecting the anxiety there. I was in many ways fortunate that I was part of a residency program in social medicine that had a moral compass and a social conscience and interested in affecting health improvement through social change. So we were that faction of practitioners who were interested in going beyond just the day-to-day treatment. And in that sense, you had a cadre of people who were a bit more open-minded, but that didn't happen everywhere. There were some places where the patients were ostracized and taken out of their rooms, moved into a different hospital. We don't want this patient here. That was sad. I'm personally glad that I had excellent mentors at the time, some of whom I'm still in touch with. Dr. Jerry Friedland comes to mind. And he and I have gotten together now 35 years later, had dinner and discussed some of the patients who we've learned so much from in those days. So it takes a sense of determination and humility to confront that reality. And I just don't know how else to describe it. A certain boldness to say, you know what, this is new, but we're going to need to figure it out. I'm not just going to be paralyzed by this. What progress can we make and how do we move forward? So it's hard to describe. Scary indeed, uncertain times, and also developing this sort of insatiable appetite for anything that was written about it, reading it, and consuming every bit of new report immediately on the spot so that you could be as aware of what was going on as possible.
Thank you. Is there anything that we didn't ask you that you want to share with us about PEPFAR or any of your work?
No, not that I can think of. You've been quite thorough. And you, as you know, PEPFAR has also mutated into becoming the global health security, and I think that's almost a survival mechanism, acknowledging that there's not going to be an endless appetite to support an AIDS program forever or in perpetuity. But the reality is that there are some lessons. If you go back in history, there are some important lessons. You know, globally, we eradicated smallpox because that was made a policy adopted by the World Health Assembly, and there was a determined effort that was maintained over time, resourced when there were shortages, they addressed them. In fact, one of the ironies of smallpox eradication that we've learned about is that vaccine shortages led to a principle of identifying cases and immunizing those around them. And that became a very successful strategy rather than immunizing everyone in the village. And I think we need to be open-minded to keep learning about new approaches to dealing with HIV. Some of the new challenges with HIV is implementing some of the preventive measures. PrEP is not fully available to people in many of these places, in spite of having antiretroviral drugs available. There are going to be new drugs. Are we going to make them available? Long injectable agents, or are we going to be stuck with the oral agents and let the world catch up later on? When's the right time to implement innovation in these lower and middle income countries? Those, to me, are some of the challenges. And then the other challenge I think that we collectively face is acknowledging that COVID was only the beginning, that we're likely to see another pandemic and other airborne diseases, and that instead of acting surprised, we better be prepared. And part of what we need is to build resilient infrastructures with a surge capacity so that as you address whatever new condition comes your way, it's not at the expense of the gains you've attained. And PEPFAR was very good at providing some of that workforce, TB programs also, but it also came at the cost of drawbacks in AIDS. And I think that's the next frontier is how do you do better at all these other conditions. And even when they appear not to be at the forefront of your mind, they're there's something, and I don't know if I said this earlier, so I apologize if I'm repeating myself, but the concept of having the fire station in every community, you hope you don't need it, but you want it there. By God, if there's a fire, you want that unit to be able to respond to the local fire. And many of these health programs operate that way. You may not appreciate their importance up until when there's that fire, and then you want them, come in, please, and help me out.
Thank you so much, Dr. Castro. We appreciate it.
You're welcome. Thank you for the work you're doing.